Hi, and welcome to 360 RN. My name is Dr. Meredith Watkins, and this is a video as part of our series on mental health nursing. In this video, we're going to talk about the mental health assessment. Now, to get the most out of these videos, make sure you grab the Mental Health Study Buddy workbooking system. It's down in the description box below. But for now, let's talk about what we're going to learn today. We have 4 goals for our learning today. We're going to explain the components of the nursing assessment for a mental health patient. We're going to talk about the purpose of a mental status exam, explain the components of a mental screening assessment, and then finally assess for scene safety, immediate safety risk, both for the patient and for others around them. Now remember that when we're doing a mental status assessment, we're always going to treat a medical emergency before we treat a mental health issue. Medical comes before mental. And so if someone has a severe depression, but they have an airway compromise, they're having a severe asthma attack right now, I'm not going to be able to help them with their severe depression if they have respiratory failure from their asthma attack. So you want to screen for any medical conditions that need urgent care before you address their mental health issues. Keep in mind that some mental health issues actually stem from a medical issue. You can have cognitive changes, for example, that are happening from an electrolyte problem or an infection. You can have psychosis related to a UTI. So it's important to rule out collaboratively with the provider any medical issues that need to be addressed before we get into the mental issues. And before you address any issues at all, you want to assess the scene to make sure that it is safe. That's the first priority, to look around the room and assess for any safety risks. Look at the patient. How is their demeanor? Do they look like they're having escalating behaviors? Do they look calm and cooperative? Are there any issues in the room around you? Do you see any things that could be used as a weapon? Do you have an exit between you and the patient and the door? You want to always keep yourself between the patient and the door so you have an exit. So being aware of your surroundings and considering scene safety is the first assessment you want to make. Now, before you get into the mental status exam, it's important to first do the general assessment. That includes noting why the patient presented to the clinic or the hospital today, what happened with that presenting problem. Complete a head-to-toe exam and note some vital signs. We want to make sure the patient is medically cleared and that there's no medical issues to address. Consider their psychosocial history, ask about their psychiatric history, their medical history, and developmental history. Ask about family history, their interpersonal relationships. Who do they live with? What roles do they have to serve in their life? Maybe they're the CEO of a company, or they're a parent, or they work at a school. What kind of roles do they serve in their day-to-day life? What's their daily functioning like? Are they performing their activities of daily living? Do they balance their checkbook? Are they able to drive a car? Do they have drug and alcohol use? And if so, to what extent? What's their sexuality, their religious or spiritual beliefs, and their cultural background and preferences? Once you've done the general assessment, then you'll move on to the specific mental status exam. Now, the purpose of the mental status exam is to evaluate mental capacity, and we do so in a variety of realms. We look at their cognition, or their thinking processes. We look at mood, behaviors, and perceptions. How do they perceive the world around them? We also screen for dysfunction in their daily living or in any of these areas, and we assess for their immediate safety for either suicidal or homicidal ideation. Now, because we love acronyms in healthcare, here's another acronym to add to your toolbox. The components of the mental status exam can be remembered using ABC stamps. A stands for appearance, B behavior, C cooperation, and then speech, thought processes, affect, mood, perceptions, and finally suicidality. We're going to break down each of these separately. A stands for appearance. You're going to note anything unusual in the person's self-care, dress, makeup, or belongings. You'll want to note if there's any abnormal things with their grooming or hygiene, as well as their clothing. Is their clothing weather appropriate, and is it setting appropriate? Next, you're going to look at behavior. You're going to look for any abnormal motor activities, level of activity, eye contact, mannerisms, and posture. We're going to look at things like abnormal eye contact, either not making eye contact at all or staring deeply into your soul. We're going to look for psychomotor retardation, also known as bradykinesia. So brady means slow, kinesthetics means movement, and so psychomotor retardation or bradykinesia means slow movement. Psychomotor activation, also known as akathisia, is the opposite side of the spectrum. It's fast, lots of movement, very active, and with akathisia, it's a feeling of restlessness that's not relieved by moving. We're going to look at the patient's physical proximity or distance. Are they getting right up in your face in an uncomfortably close way, or are they extremely far away from you? There is a understanding of personal space for patients with normal thought processing, and so that can be found as an abnormal behavior. We want to look for stereotypes or mannerisms, repetitive movements that the patient continues to make. We want to look for tics, and we want to look for tremors. C stands for cooperation. You want to note the person's attitude toward the interview. Someone who's engaged and participatory, you're going to get more information of, and so it just helps to frame the understanding of the interview. You're going to see how the patients are doing answering questions, interacting with the nurse, if they have a closed or open posture, and if they're actively listening. The next thing is speech. You're going to look for any abnormalities in their rate, tone, and ability to express or comprehend language. Now, you may look for things like slowed or delayed speech, a prolonged latency to response, meaning you ask a question and there's a gap between when you ask the question and when they respond. Prosody, decreased prosody, means that they have less intonation in their voice. Typically, when people talk, they have inflections. Their voice goes higher and their voice goes lower, and that's part of normal speech patterns. But someone who has prosody, a decreased prosody, is going to have the same level of speech at all times. See the difference? And then finally is the example of pressured speech. Pressured speech, you can hear kind of like a locomotive, where the speech starts slow and it gets faster and faster and faster, and they just can't help themselves but keep talking faster. Pressured speech. Now, when we're assessing a patient's thoughts, we're assessing both their thought process and their thought content. With thought process, we're looking at their coherence and speed of thought. And with content, we're noting if they have any delusions, obsessions, or compulsions. We're going to talk about each section of these thought assessments separately. So for thought process, coherence, we're going to be looking for any illogical thoughts or sentences that don't make sense. So circumstantial or tangential is when a patient goes off on a tangent. So you might be talking about what they had for breakfast today, and then they had an orange. And did you know that oranges are made in Florida, and Florida has beautiful beaches, but then the sharks can be really dangerous? That's going off on a tangent. We were talking about breakfast, and now we're talking about sharks in Florida. The loosening of associations is another thing to assess. This is when the patient has two different thoughts, and in their head, they have some kind of linkage, but it's a very loose linkage. For example, the patient might say, "I like to dance. My feet are wet." Okay, well, feet are involved in both. Both feet are wet, and you use your feet to dance. But it's a very long stretch in how you get to that loose association. The next one is neologisms, making up new words. And then the last one is word salad, putting a bunch of different words together in a sentence, but the sentence doesn't have coherence when you put all of those words together. The second thing we'll assess on thought process is the speed of thoughts. Note how quickly the patient processes or speaks their thoughts. For example, the patient might have mutism, where they're not speaking at all. They might have thought blocking, where they are talking with you about something and all of a sudden they just stop talking in the middle of their thought. They may have racing thoughts, where their thoughts are not only sped up, but they're just a flurry of thoughts going on in their head. And then they might have a flight of ideas. And a flight of ideas and racing thoughts are kind of the same, except that racing thoughts are the speed of which the thoughts happen, and a flight of ideas are the number of thoughts that someone has all at once. After we look at thought process, we start to look at thought content. And the first section of that is delusions. Now, a delusion is a false fixed belief, something that the patient believes strongly, even when presented with evidence to the contrary. Delusions can be paranoid delusions, where they think someone's after them. Of reference means that they think certain things are meant toward them. So they might see a license plate on a car, and the numbers on the license plate they think are a reference to them of a code that they're supposed to crack. Or they might hear a commercial on the TV, and it's about a specific vacuum cleaner, but there's something that they find is coded toward them in that commercial. Somatic delusions are when the patient feels like they have some kind of physical illness, like cancer or a tumor or something, and there is no medical proof of the way they feel, but they believe it very strongly. Grandiose delusions means that they think that they might be president next year, that they're running the country, that they are the most powerful person in the world. And then delusions of control mean that they think that someone is trying to control them, control their mind, control their movement. It's similar to paranoid delusions. The second thought content to assess is obsessions. Obsessions are any repeated thoughts or urges that are unwanted and intrusive. They can have obsessions about contamination, about whether things are clean or dirty, or environmental concerns, as in terms of thinking things are toxic or that they're being exposed to things. They could have somatic obsessions, where they're obsessed with some kind of illness or worried about health. They can have aggressive, sexual, forbidden thoughts or loss of control obsessions. And they can have pathological doubting, where they doubt everything that people tell them. So they might have been in a 20-year marriage, but they doubt every bit that their partner loves them, that their partner wants to be with them, that they are wanted. So these are different types of obsessions that patients can have. And obsessions often go along with compulsions. Compulsions are any repeated behavior that the patient feels the urge to do in response to an obsession. So let's pretend that the patient has an obsession about cleanliness and that they feel like they are always being contaminated. They may feel an urge to repeatedly, frequently wash their hands to the point where their hands become raw and cracked and red. So compulsions can be things like cleaning or washing, checking or seeking reassurance. Maybe they have to close the front door 3 times before they feel comfortable with that. Ordering and organizing and saving and hoarding are all examples of compulsions. A stands for affect. We're going to note the patient's expression of emotion. And does their emotion match their thought content? So does their emotion match what they're saying? We might notice a constricted range of affect, so that the patient has absolutely no fluctuation in their affect. We also call this a flat affect. They might be anhedonic. Anhedonic means lacking enjoyment in life. Do they have an expansive range of affect or wide? We can also notice this as an inappropriate or labile affect. So a wide expansive means they have big emotions all over the place, kind of like a roller coaster. But the labile affect means that their emotions can change on a dime. So one second they're laughing and thinking everything's hilarious. The next moment they're screaming and very, very angry. That's a labile affect, where it goes up and down. M stands for mood. We're going to ask about any depressive mood, anxiety, and manic symptoms. We're going to determine the intensity and the stability of any mood symptoms they have. Now, the patient might be euphoric, feeling very, very good, on top of the world. They might be manic, where they are elated to the point of extreme high emotions, or hypomanic, where they're feeling somewhere in between. They may feel depressed with a very low mood, or they may feel anxious and worried. Then we want to look at the patient's perception. We're going to ask about their perception of the world around them. We're noting any hallucinations or perceptual disturbances that the patient might have. These can include auditory hallucinations when they hear things of people that aren't there. They may have visual hallucinations where they see things that aren't there. They may have tactile hallucinations where they feel like someone's maybe tapping them on the shoulder, but there's no one there. And with these hallucinations, we want to note if they're responding to internal stimuli. For example, if they are hearing someone say, go bang your head against the wall, and then they go and do that. So when patients are responding to hallucinations, it's more dangerous because those hallucinations can cause harm to the patient. Next, we're going to ask about suicidality, and this is about recognizing immediate risk of harm to the patient or others. So we're going to ask about suicidal or homicidal thoughts or actions or ideas. So for suicidal ideation, we want to determine if that's active or passive. And the way you'll know the difference is whether or not the patient has a plan. So if the patient says, yeah, I'd rather be dead, I don't really want to be here, but has no plan to do anything about that, that's a lower level of risk. Whereas a patient who said, yes, I'm suicidal and I'm going to go jump in front of traffic next week, that's more high risk because the patient has made a specific plan. In addition to that, we want to think about the lethality of their plan. Do they have the means to complete their plan, and how dangerous is their plan? What's the likelihood that they would die if they did the plan that they're thinking about? Now, with homicidal ideation, that means that they're thinking about harming someone else. We want to know, is this in general to everyone around you, or is there someone specific? Keep in mind, some states have a duty to warn law that the provider, psychiatrist or medical doctor, would need to warn that specific person that this patient does have these homicidal tendencies toward that person. And again, we want to ask about a plan or timeline when we're assessing the risk level for this patient. And then to wrap it up, there's some other mental status assessments that are just good to do in general. Level of consciousness. Do they have insight and judgment? Insight means, do they understand what's going on with their own mental illness? Do they know kind of what caused it and what they're struggling with and how they're working on it? Or are they completely lacking insight into that process? We also want to understand their judgment. Do they have judgment on how to keep themselves safe? So one of the reasons when we cross the street with little kids that we hold their hand is because they don't have judgment yet on how to safely cross the street. And sometimes even adults with mental health disorders can lack judgment and they're not able to keep themselves safe. So understanding their assessment of judgment can help us to know what parameters of safety we need to put in place for that patient. Then we want to look at their cognitive functioning. We're going to talk about cognitive functioning a lot more in detail when we get into the neurocognitive lecture. But for now, we're going to be assessing things like their orientation. Are you alert and oriented times 3 or 4? What's their memory like? What's their attention and concentration abilities? How about their reading and writing levels? And just overall knowledge base and education. And finally, we want to consider the reliability of the patient as a historian. Not all patients are going to give us an accurate account of their life because they may not be able to recall those things, or they may have perception issues. So consider the reliability of the patient as a historian when you're gathering data. And you may need to get data from other sources like loved ones or the medical record in order to establish baseline data for the patient. That's going to wrap it up for our learning on mental status assessment for mental health patients. Thank you so much for studying with me today. Remember, you are smart, you are capable, you are loved, and you got this. I'll see you next time.